From Microbe TV, this is Infectious Disease Puscast, episode 81, recorded on Wednesday, May 21st, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and not joining me today is Dr. Sarah Dong. She's actually taken this episode off. She's on vacation, and I suggested that unlike Vincent and myself, who do not have good work-life balance, that she go ahead and take this one off. So welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Since Sarah's not around for banter, I guess we're just going to move right ahead. Puscast is a review of the infectious disease literature for the last 2 weeks that I found interesting or entertaining. And now on to literature, shall we? So we're going to start with our viral section, and I like to remind people, encourage people to listen to This Week in Virology, both the deep dive and the clinical update. And we have a couple of viral papers this week, this 2 week, I guess. The article Tecovirimat for Clade 1 MPXV, so that's the monkeypox virus infection, which causes Mpox, in the Democratic Republic of Congo, published in the New England Journal of Medicine. So these are the results of a double-blind, randomized, placebo-controlled trial of Tecovirimat in patients with Mpox in the DRC. Patients with at least one Mpox skin lesion and positive PCR for Clade 1 monkeypox virus were assigned in a 1-to-1 ratio to receive Tecovirimat or placebo. Remind people that the virology, it's still called monkeypox. We call the disease Mpox. All patients received supportive care. The primary endpoint was resolution of Mpox lesions measured in number of days after randomization. 295 to receive Tecovirimat, 302 ended up with placebo. The median time from randomization to lesion resolution was 7 days with Tecovirimat, 8 days with placebo. Really not seeing statistically significant differences here. Results were really similar, whether patients began the trial regimen within 7 days, after the reported onset of symptoms, or after 7 days. They have a chart where you can really follow this out. We're really not seeing much benefit of Tecovirimat over placebo here. So a little bit disappointing. Great drug in the animals, but not doing such a great job here. We also have the article, Remdesivir associated with reduced mortality in hospitalized COVID-19 patients, treatment effectiveness using real-world data and natural language processing, published in BMC Infectious Diseases. And here these investigators aim to use real-world evidence generated by artificial intelligence techniques to assess the impact of Remdesivir on COVID-19 outcomes. They're using this natural language NLP technology. And they're looking at clinical information from EHRs, retrospectively hospitalized patients, COVID-19, moderate to severe, in 3 Spanish hospitals. And then they end up among the Remdesivir eligible. We have treated and untreated, propensity score matching, end up with 7,651,773 EHRs, 84,408 patients, 6,756 were detected with the moderate to severe COVID-19. Study population was defined with 4,882 Remdesivir eligible patients. Mean age 72, a little over half were male. Total of 812 were classified as Remdesivir positive, matched to 2,703 Remdesivir negative, and the hazard ratio for in-hospital mortality at 28 days was 0.73. So they're giving us a statistically significant reduction in inpatient mortality when you match here. So I just want to discuss where this fits in. So we're seeing this 37% reduction, depending on how you do the calculation here. And how does this compare with, well, ACTT1? There we had a hazard ratio of 0.73, so sort of a 20, very similar, 27%. WHO Solidarity Trial, 13% reduction in inpatient mortality. Recent meta-analysis of RCTs, including data from more than 10,000 patients, more than 40 countries. There we were seeing a significant 12% reduction in all-cause inpatient mortality. Another study with patients, we're seeing remdesivir reduced inpatient mortality by 40% overall, 37% in those needing low-flow oxygen. Data from the large premier healthcare database in the U.S., a 24% and 12% reduction in in-hospital mortality at 14 and 28 days, and a similar 33% reduction in inpatient mortality reported in a comparative matched analysis of data from a phase 3 randomized trial of remdesivir in COVID-19, and a real-world retrospective cohort study of patients receiving standard of care, and a large U.S. study comparing patients receiving remdesivir, found remdesivir reduced in-hospital mortality by 17% overall and 23% in patients needing high-flow or non-invasive ventilation. So really building on a number of studies. So I know there's a lot of people out there, they make these sort of offhand comments. Oh, this remdesivir is just really not like making much of a difference anymore. This is a big difference that we're seeing in a number of excellent studies. So those high-risk patients, here's the evidence. Okay, moving away from COVID for a moment, the article Impact of Most Promising Ebola Therapies on Survival, a secondary analysis during the 10th outbreak in the Democratic Republic of Congo, published in Virology Journal. So they're looking at MAB 114, Regeneron, EB3, no V there, remdesivir, and ZMapp, monoclonal antibody-based treatments, compared and shown to be promising therapies. But there's been no comparison between these medications. So this study aimed to examine the contribution of each regimen compared to a standard treatment. So vaccinated Ebola virus disease patients were 1.7 times less likely to die compared to unvaccinated. So good job there. Delayed care and treatment at Ebola virus disease treatment centers, they say increased mortality by 5% for each day following symptom onset, right? So you really want to get in there quickly. You don't want to wait. Compared to standard treatment groups, adjusted mortality significantly reduced in all the MAB groups. So the MAB 114, we had about 73% reduction. The Regeneron EB3, here we had about a 74% reduction. Remdesivir, again, interesting, Ebola remdesivir, we are seeing a 0.38. So we're seeing about a 62% reduction. ZMapp, we're seeing about a 53%. So, all right, good stuff there in the viral section. Moving on to bacterial, be sure to listen to This Week in Microbiology. Enjoy listening to the crew there, some great recent episodes. And we have a good one to start us off here for our bacterial section, the article Comparative Effectiveness of Azithromycin versus Doxycycline in Hospitalized Patients with Community-Acquired Pneumonia Treated with Beta-Lactams, a multi-center matched cohort study in CID. This is that question, right? You got that beta-lactam, maybe you got your ceftriaxone on board, and you're trying to decide, should I add azithromycin or doxycycline? Does it really matter? Well, retrospective study where they evaluated patients with community-acquired pneumonia admitted to the Mayo Clinic May 2018 to September 2022, treated with either azithromycin or doxycycline in combination with that beta-lactam. The primary outcome was mortality. It's a pretty hard endpoint. Patients were 1-to-1 matched according to the presence of congestive heart failure, coronary artery disease, COPD, HIV, recent immunosuppressant use, pneumonia severity index class, among 8,492 patients, 5,810 for azithro, 2,682 for doxycycline, 2,671 doxycycline treated patients were matched with azithromycin treated ones. In-hospital mortality was significantly lower in the azithromycin group than in the doxy group. And we're seeing an odds ratio of 0.71. So that's a 29% reduction. Kind of amazing. Just picking azithromycin over doxy. 90-day mortality hazard ratio 0.83, so 17% reduction in 90-day mortality. So azithromycin also had significantly more hospital-free days than those on doxycycline. So got really nice graphical abstract here where you can just see all the benefits. So really, I have to say a little bit surprising to me that azithromycin did so much better than doxycycline, but here's the data. All right, the article, Diet and Risk for Incident Diverticulosis in Women, a prospective cohort study, was published in Annals of Internal Medicine. Oh my gosh, when will we stop saying things that are not true? So in a nutshell, 1,531 cases of incident diverticulitis for 415,103 person-years of follow-up. Intake of peanuts, nuts, and seeds. Adjusted hazard ratio of 1.07, and fresh fruits with edible seeds. Remember the strawberries was adjusted hazard ratio of 1.06. So there was a reduced risk for incident diverticulitis in women in the highest quartile of healthy diets compared to the lowest quartile. So which of these diets? So this is the DASH diet, the healthy eating index. So DASH diet, actually a hazard ratio of 0.77. So interesting enough, instead of all this mythology about peanuts, nuts, and seeds and fresh fruits with edible seeds, which really trended in the wrong direction, not particularly helpful, a DASH diet adjusted hazard ratio of 0.77, so 23% reduction. Healthy eating index, 0.78. Alternative healthy eating index, 0.81. And the alternative Mediterranean diet, worst of all, with a 0.91 overlapping confidence interval. So it looks like all these DASH and healthy eating approaches actually reduce the risk, where peanuts, nuts, seeds, edible seeds, fruits, not really doing what we've been telling people. All right, the article, BCG Revaccination for the Prevention of Mycobacterium Tuberculosis Infection, was published in New England Journal of Medicine. So negative but interesting data, and really going to take a little bit to kind of figure out what's going on here. So for background, in a previous phase 2 trial, BCG revaccination was not shown to provide protection from primary tuberculosis infection, but prevented sustained M. tuberculosis infection defined by initial conversion on a quantiferon gold test from negative to positive, followed by 2 additional positive quantiferon tests at 3 and 6 months after the initial conversion. I'm going to circle back, like, what does that even mean? So there was this prior study where they found this interesting phenomenon, which they're going to tell us is important. But let's go through what happened here. So here we've got a total of 1,836 participants. They undergo randomization so that 918 receive the BCG vaccine, 917 receive placebo. And then after a median of 30 months of follow-up, they're going to look at this sustained quantiferon gold test conversion, which they see observed in 62 of the 871 in the BCG vaccine group, 59 of the 849 in the placebo group. So really not seeing that when you give this extra BCG, you're impacting this this endpoint. So what is this sustained infection they're talking about, right? So, we've always taught, like, you get exposed to tuberculosis, it becomes latent, you stay quantiferon gold or PPD positive for life. Now, one interpretation of the significant result for the prevention of sustained M. tuberculosis infection is that this quantiferon test reversion could indicate a successful immune control, or, you ready for this? Clearance of M. tuberculosis, thus decreasing the risk of progression to disease. So this concept's interesting. So, MTB immunoreactivity is commonly considered to persist lifelong and to confer a lifetime of disease risk reduction. So reviewing this topic, they identified a study that monitored this TB progression risk following this observed interferon gamma release assay reversion. So South African adolescents were assessed every 6 months for 2 years, and the TB incidence following this reversion was observed to be 1,470 compared to 1,050 in those who were positive throughout. So not really clear what to make of this, but just sort of negative data, independent of what to make of this. All right, you got that? It's thick as clear as mud. The impact of diet on C. diff infection, a review published in JID. So look, second one here, can diet make a difference? As of 2025, 2 FDA-approved microbial therapeutics have been developed to restore in the intestinal microbiome in patients with recurrent C. diff. We've got the Rebiota. This is a human-derived microbiome suspension administered via enema, and Voust, which is an orally administered purified bacterial spore product rich in firmicutes from healthy donors. Still not the magical cure we want, as Rebiota has a recurrence rate of 29.4 versus 42.5 in placebo. Voust was 12% versus 40% in placebo. There's some really cool biochemistry in this paper with a discussion of how the different gut microbiomes compete with regard to the energy sources or nutrients in the gut, such as amino acids or carbohydrates. Also a review of the negative impact of high-fat diets on C. diff mortality in animal models. Now, a reminder that mice are not humans, with mice having a shorter small intestine and lacking intestinal folds. Indeed, the average surface area of small intestine to colon in mouse is 18 compared to, you ready for this, 400 in humans. Also, a very different microbiome in mice, as 85% of the mouse intestinal microbiota is not found in humans. Still lots more to learn, but it looks like a lower fat, higher fiber diet with certain vegetables like asparagus might lower the risk of recurrence, where things like taking too much zinc and eating too much of certain carbohydrates might increase the risks. All right, we've got the article. Another one of my pet peeve favorites, the article Cefazolin versus Anti-Staphylococcal Penicillins for the Treatment of Methicillin-Susceptible Staph aureus Bacteremia, a systematic review and meta-analysis. This was published in Clinical Microbiology and Infection. So why don't we look at the data here and draw our conclusions? So there's debate on whether cefazolin or anti-staphylococcal penicillins should be the first-line treatment for methicillin-susceptible Staph aureus, MSSA, right? I always feel like I can tell who the consultant is depending on what the recommendation is. So here, these investigators conducted a systematic review and meta-analysis comparing cefazolin to each of the individual anti-staphylococcal penicillins for MSSA bacteremia. So they updated a 2019 systematic review, but specifically focused on evaluating outcomes for individual anti-staphylococcal penicillins. Primary outcome, 30-day all-cause mortality. They assessed for non-inferiority of cefazolin using a pre-specified non-inferior margin of a pooled odds ratio. Yeah, let's move past that. Secondary outcomes were 90-day mortality, treatment-related adverse events, discontinuation due to toxicity, and nephrotoxicity. So here's what we find. No randomized data have been published. 30 observational studies at moderate or high risk of bias were included, which comprised 3,869 patients who received cefazolin, 11,644 patients who received anti-staphylococcal penicillins, and they break that down into flucloxacillin and nafcillin and cloxacillin and oxacillin. Now, cefazolin was associated with a reduced odds of 30-day all-cause mortality, 27% reduction. So odds ratio of 0.73 compared to anti-staphylococcal penicillins. Point estimates favored cefazolin for 90-day mortality, adverse events, nephrotoxicity, discontinuation due to toxicity. So a major caveat is just about every study was rated as having a high risk of bias. Some great forest plots, but I will say just about no suggestion that any anti-staphylococcal penicillin was better or even equal to cefazolin. All right, that's what we got. Moving on to fungal. I hope everyone's enjoying The Last of Us Season 2. The last episode I really liked. I feel like it was sort of okay. I got a little uneasy. Now I'm feeling a little bit better. The article, Candida auris, they had me right there. Candida auris is emerging as a prevalent urinary pathogen published in PLOS Pathogens. Recently, actually, we had, I'm going to do the math on this, like 10% of the people on our service at the academic center had an issue with Candida auris. So I was sort of at the Candida auris mecca. Urinary tract infections are one of the most common infections, with a subgroup of these infections, CAUDIs, accounting for 40% of nosocomial infections. While the majority of CAUDI pathogens are bacterial, the second most common pathogen is the fungus Candida albicans. In recent years, Candida auris has increasingly been isolated from urine, indicating C. auris's potential as a urinary pathogen. So here they're going to analyze 12,996 C. auris clinical strains and their frequency related to urine and urinary catheters. They identified urine as the second most common C. auris isolation source in the U.S. and the third most common worldwide. Anecdotally, C. auris urine isolates are often associated with urinary catheters and high mortality rates. Furthermore, there has been an early indication of urinary isolates developing echinocandin resistance. So some really nice figures in this paper as well. All right, we got a couple more. We're doing well on the fungi this time. A symbiotic filamentous gut fungus ameliorates MASH via a secondary metabolite, CERS6 ceramide axis, published in Science, right? So here we're going to treat people with a fungus, and we're going to cure their steatohepatitis. So the investigators identified a filamentous fungus named Fusarium foetans that negatively associated with the human metabolic disease phenotype, metabolic dysfunction-associated steatohepatitis, MASH. They designed a fungal isolation chip, a phi-chip-based optimized in situ cultivation system for gut fungi. They're calling this Focus G, which helps obtain more unartificial and unculturable fungi. So using Focus G, they systematically isolated 2,137 fungal strains from fecal samples of volunteers from 5 different geographic areas within China. The Focus G identified Fusarium species as symbiotic fungi that can acclimatize to anaerobic conditions found in the host colon. They got this really nice figure where they sort of walk you through intestinal tissue enzyme activity analysis, and bioactive guided separation showed that F. foetans reverses metabolic dysfunction associated with fatty liver disease by producing the secondary metabolite FFC1, which inhibited intestinal CERS6 activity and reduced serum levels of ceramides in mice. All right, so we're there in mice, but I think I talked last one of the articles about just how different mice and humans are. All right, the article, Outcome Predictors of Candida Prosthetic Joint Infections, a Systemic Review and Meta-Analysis, published in OFID. This was so good, I almost put it in twice. Here, a systematic literature review was performed in PubMed, Medline, Embase, and Web of Science until July 2024. Articles, cohorts, case series, case reports reporting individual data of adult patients were included. Total of 385 CPJI, Candida prosthetic joint infections, 204 hip, 152 knee, 110 publications. Polymicrobial infections accounted for a third. Candida albicans, 47.2, with the predominant species followed by Candida parapsilus, that was 28.6. Multivariate analysis, independent predictors of failure were co-infection with Staph auris, not surprised there, and debridement retention of the prosthesis, while first-line therapy with amphotericin B was associated with success. No difference according to the type of prosthesis exchange procedure, whether it was 1, 2, or 3 stages was found. An interesting use of local antifungal therapy, this antifungal drug impregnated spacer approach, had no significant impact on outcome. All right, the MMWR cave-associated histoplasmosis outbreak among travelers returning from Costa Rica, Georgia, Texas, and Washington, December 2024 through January 2025. So what are these people doing? What are they doing crawling around in caves? I don't know. I understand, being a amateur spelunker myself. On January 17, 2025, a Georgia infectious disease physician notified CDC of suspected histoplasmosis cases among 12 members of an extended family from households in Georgia, Texas, and Washington. They were answering the phones back then. The ill family members included 6 adults aged 42 to 49 years, 6 children aged 8 to 16. They had recently returned from Costa Rica, where they toured a cave linked to a previous histoplasmosis outbreak. They all reported seeing bats and having direct contact with bat droppings while crawling and squeezing through tight spaces in the cave. All persons became mildly or moderately ill after returning to the United States, 8 to 19 days after exposure. Signs and symptoms included headache, malaise, fever, night sweats, myalgia, respiratory, and GI symptoms. The one family member who did not tour the cave did just fine. 5 adults and 1 child sought medical care at urgent or primary care facilities. You ready for this? No travel history was elicited. They didn't ask. Among these 6 patients, 3 received antibiotics, 2 received corticosteroids. That's helpful, right? Let's immunosuppress someone. And 1 received a cough suppressant. 1 adult was referred to an ER and hospitalized because of abnormal chest radiography. And they scared them and scared the bejesus out of them, talking about lung cancer. However, when healthcare providers actually asked about the patient's travel history the next day and learned of the visit to a Costa Rican cave with bats and histoplasmosis became the suspected diagnosis. The patient initially was prescribed voriconazole, discharged 2 days after admission. Treatment was subsequently changed to itraconazole. By 28 days after exposure, all 12 affected family members had recovered or were improving, consistent with the clinical course of mild and moderate histoplasmosis. All right, remember to ask that travel history. Parasitic. All right, remember to listen to This Week in Parasitism. An announcement here. USDA suspends southern border livestock imports over New World screwworm threat. So I'm sure everyone's been hearing all about this because, of course, this is what the media is covering. But USDA Secretary Brooke Rollins suspended the import of live cattle, horses, and bison across the United States border with Mexico due to the rapid northward spread of New World screwworm, which can cause cattle loss and has also been linked to sporadic infections in people. So, New World screwworm, NWS, we all need our 3-letter acronym, is spread by a parasitic fly. So this fly actually attacks healthy tissue through wounds or orifices, typically in livestock, wildlife, pets, and sometimes people. The fly deposits larvae that burrow deep into the wound and cause severe damage. I mean, they just eat. It's horrible to say. The disease was eradicated in the United States using sterile insect techniques. They irradiate the mosquitoes. They release them. Now, since 1994, the United States, Mexico, and Panama have collaborated on a project to drop millions of sterile flies over jungle area at the Panama-Colombia border to keep the fly from spreading northward. In 2023, detections surged dramatically in Panama, subsequent detections in Costa Rica, Nicaragua, Honduras, Guatemala, Belize, El Salvador, and now Mexico. All right. The article, Moxidectin ran combination therapies for lymphatic filariasis, an open-label, observer-masked, randomized controlled trial, was published in The Lancet Infectious Diseases. So lymphatic filariasis caused by Wuchereria bancrofti, say that 6 times, causes hydroceles and lymphedema in millions of individuals worldwide. Annual mass drug administration of ivermectin plus albendazole temporarily clears the microfilaria from the blood of infected individuals and is used in Africa to reduce Wuchereria bancrofti transmission. Now, this study aimed to evaluate whether moxidectin combination therapies are superior to ivermectin combination therapies for clearance of W. bancrofti microfilariae. Open label, parallel assignment, masked observers, randomized superiority clinical trial in Côte d'Ivoire. They used gender stratified block randomization to sequentially assign adults with bancroftian filariasis to receive annual ivermectin plus albendazole or one of 3 single-dose regimens, moxidectin plus albendazole, called that MOX-A, ivermectin plus DEC, so that's the DEC plus albendazole, or moxidectin plus DEC plus albendazole, so the MOXI-DA. In this study, single-dose MOX-A was superior to ivermectin plus albendazole for Wucheria bancrofti microfilarial clearance at 12 months and provided prolonged microfilarial clearance for most participants. And these results suggest that this MOX-A approach, so this is the MOXI dectin plus albendazole, could be a powerful tool to accelerate the elimination of lymphatic filariasis in Africa. All right, and that brings us to the end of this Puscast. As always, the references for the show are available at microbe.tv, the home of our growing multimedia empire. You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube. I like YouTube because then we get the counts, right? We know how many people are listening. And when you do that, make sure to subscribe, like us, ring the bell, leave some really nice comments. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. Also a great place for you to plug your paper. Send them our way. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders at parasiteswithoutborders.com and click on our donate button. Sarah Dong is not with us, but you can find her at Sarah Windong at Blue Sky, at Febrile Podcast, or at febrilepodcast.com. I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you. End dictation. Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.